So we next go on to Dr. Pooja Khamar, who actually needs no introduction, belongs to the next generation, but is taking refractive surgery forward in our country and beyond in leaps and bounds. So she's going to be talking on collagen imaging and role in refractive surgery.
Thank you, ma'am. That was a very generous introduction. I think I have a lot more to do than you introduced me as. So, as ma'am said, what I'm going to be talking about is collagen imaging and its role in refractive surgery. It's a little bit futuristic, but yes, like how we've, as Rajesh was saying, how we've moved from a topography to a tomography and now biomechanics, I think this will be a very well integrated technology in future as well. So, ma'am is of course going to be speaking about biomechanics, but we do come across scenarios in our practice every day where topographies are absolutely normal, but your biomechanics or indices like CBI, TBI do not match with what your topography is trying to tell you. So we do get confused. However, we do our best, and out of all the options available, like KP sir said, we can choose whether to do a LASIK, SMILE, an extra procedure, or a trans-PRK, or a phakic IOL. And based on all these parameters, we do have wonderful algorithms also, like when to choose which procedure for each of these patients. Then why is the need to understand the collagen? We do have already indices which tells us whether this is a healthy cornea, whether it's a suspect keratoconus, whether you should do a refractive surgery or not. However, in spite of all this, we do come across cases. These are two patients. First patient is absolutely normal. Second patient has a borderline biomechanics. However, the first patient who was absolutely normal landed up having an ectasia, but the second patient who had a borderline biomechanics is doing well. It's post-surgery around 8 years, a well-centered ablation, nothing has happened. So what is driving these ectasias? Why is this? What are these unknown factors? So we needed a solution to it. So there are enough studies which have happened on from various in vivo studies using probably cadaveric eyes or lenticules to understand the collagen structures. And what we have proven till now is that if your collagen density is lower to begin with, then even if your topographies or if your biomechanics are healthy, those patients are still at higher risk of developing ectasia. But at this point of time, only way to identify the collagen is to excise the tissue and do it, which is not practical in daily practice. So is there a way where we can have a non-invasive tool to study this collagen fibril orientation? And can we translate this knowledge into clinics for refractive surgery screening patients and choose the right procedure for them? So we have built this polarization sensitive OCT. It's nothing like but your like what you use SLO in your glaucoma practices. It's a similar principle where a polarized light is thrown on the patient's cornea, and all the structures of the cornea is going to take up this polarized light, but the stroma is going to bifringens it. So that's how we use this advantage, and we study the collagen of the patient. So why not other OCTs? Why not any existing commercialized OCTs? Because we need a higher depth of the bandwidth, the pupil detection, the image depth resolution has to be different, the pixel and all that. So that is much more superior in polarization sensitive OCT compared to other structures. And because of that, in addition to epithelial thickness on your stromal thickness, it also gives you the Bowman's thickness. You can actually quantify what is the Bowman's thickness in different layers. And you can also study the collagen orientation, like how dense the collagen is, whether it's normal or not. So why is Bowman's layer important? Because if you see this patchy Bowman's layer where it's thin in one area and whether it's thick in one area, this is a sign of a thin or an irregular Bowman's membrane, and this is going to be unable to maintain the integrity. So if you do any surgery on these patients are at higher risk of developing ectasia. However, if you see this thicker Bowman's, which is even all over, this is a very good Bowman's, and if whatever procedure you do on this patient is going to like have a good integrity post-surgery, so there are least chances of ectasia. That is one of the role. And the other thing what we get is, this is the collagen orientation what you get. So in simpler terms like a topography, darker the blue or violet you see means denser the collagen is in that area and it's well aligned. But if you see the lighter blues, that means it's on the weaker side. So this is what we see in a formfrous keratoconus case. If you can clearly see it's a formfrous keratoconus case, and there is a partial loss of orientation and arrangement of the collagen. And in a keratoconic case, there is a complete loss of orientation and arrangement of the collagen. You can see that the fibrils are not well aligned, and they are very haphazard, and you can see lots of green, yellow, and red. That means it's weaker. So how are we going to apply this knowledge to clinics? Of course, we'll have topography and biomechanics to help us. But if you have a collagen imaging, it will able to tell us how is your thickness of the Bowmans and how is your collagen orientation, whether it's normal, whether it's a patchy Bowmans with an abnormal collagen, and whether everything is abnormal. And based on that, you can choose. If everything is fine, you can choose a procedure of your preference. But if you have a thin Bowmans with a normal collagen level, you can choose a PRK or a SMILE extra procedure for lower dioptric error. Or if it's a higher diopter, you can choose a phakic IOL. If it's a thick Bowmans but an abnormal collagen orientation, you choose to do a trans PRK extra if it's a lower dioptric error, or a phakic IOL if it's on the higher side. And if everything is abnormal, you know that this is not a patient who deserves a corneal-based procedure, but you need to do a phakic IOL. So let's take these two case examples. First case, you can see a little bit of inferior steepening is there, and a little bit of posterior elevation. And the indices are on the abnormal range, whereas here absolutely everything is on the normal side. But if you go ahead and see, first patient has a healthy Bowmans, completely healthy Bowmans, and this patient has a thin Bowmans layer. And the patient who has apparently a healthy looking topography has a complete loss of orientation of collagen in this area, whereas this patient has a normal orientation of collagen. So once we have a good amount of data in which once this is commercialized, here I will probably go ahead and do a refractive surgery, probably a trans PRK, but here I will not do it because this is the patient who is likely at a risk of developing ectasias. So to conclude, yes, we are developing one of the first polarization sensitive OCT which can be used in clinics to study the collagen orientation and arrangement. And it can help us to differentiate suspicious corneas, which can be revealed with a unique distribution of collagen before their topographic manifestations has started. And it can become an integral part of refractive surgery screening in future to identify the warning signs in seemingly healthy cornea posted for refractive surgery. So we are also building software which can help tell us the actual orientation. You can see how disoriented these fibers are in the keratoconich eyes and in a suspicious topography also. So this will also be there once we commercialize it. And the day is not far because already the process of commercialization has started, and the future in next few years is going to be a combination of corneal tomography, epithelial mapping, and a polarization sensitive OCT which is going to be into your clinics along with retinal and glaucoma imaging in one device. Thank you.